Hi everyone, this is Maria Fakis, and I'm here talking to Mel Cohen. And Mel is from Fertility Center of California. He also has male fertility specialties. So Mel, maybe instead of me introducing all of the different hats you wear, would you share? Because I mean, it's phenomenal how much you do and what you do.
Well, I'm very, very blessed, and it's nice to be with you, Maria. I am the Chief Operating Officer for Dr. Martin Bastuba, who's a male fertility subspecialist, working with males who, when families are having difficulty having a pregnancy and there may be a male factor, we get involved. So we've got multiple companies that deal with those different things, from the basic urology and physical part of it to sperm analysis to long-term storage to short-term storage facilities to doing IUIs, just a number of different things. And I'm blessed to be able to provide leadership in those corporations.
Well, thank you so much. Mel has been phenomenal, and I know everything that Dr. Bastuba does and his team. Guys, I cannot say enough great things about their work. So I think I'm one of their biggest advocates. So anytime when our families have questions about male fertility, we always recommend them to Dr. Bastuba and his team. So today, actually, I would like to brainstorm a little bit with Mel, just really understanding the semen analysis, but also understanding collection and cryopreservation of sperm, because as Mel has mentioned many times, there are different purposes for which, and how processes will be organized around your needs. Okay. And I think this is actually a very big misconception that many families have. And sometimes we're thinking, okay, I'm just I'm just doing it for all of the above, but it's really not the same way. And the way it will be analyzed, the way it will be cryopreserved, yes, the way it will be stored, it will be very different depending on your needs. So, Mel, yes, the start with, well, maybe with bringing some of the background information for us. And
So,
if you're all kid and don't know anything.
so let's start right at the very, very beginning. When you go to a doctor and the doctor takes a blood sample from you, and he's analyzing something, when the results come back, there's always a range, a high and a low number. And you want your sample, that whatever we're looking at, to be in between that. That's because if you've got too much of something, it's no good. And if you've got too little of something, it's no good. Our brain makes two different hormones, both on the female side and on the male side. On the male side, we produce what's called luteinizing hormone, and that luteinizing hormone goes down into our testicles and it produces testosterone. In females, luteinizing hormone goes down and makes estrogen. So estrogen and testosterone are very, very close to each other, but we need testosterone to produce sperm, and we also need it to create erections. But too much is no good, too little is no good. On the other side, we have another hormone that gets dropped from the pituitary gland, and it's called FSH, or follicular stimulating hormone. That goes down to the testicles and it's food for sperm. So it allows those sperm to actually grow. And then we've got the FSH in females, which allow them to develop their eggs that are released every single month. On the male side, a male sperm that is born today can take upwards of 70 to 90 days before it actually reaches the ejaculate. And we're not going to talk too much about the physiology of how it's produced, and we certainly can at some point in time in the future. But for now, let's say that a man wants to have a semen analysis where he is looking to have children or just wants to know what his status is.
Mhm.
The first thing we're going to ask him to do is have anywhere between 2 days of abstinence, but no more than 5 days. When we're young puppies, under our 20s, we can ejaculate every day and fill up the tank again for the next time. But as we get older, past our 20s, it takes a day, day and a half before it refills. So we need to do it every other day. We want at least 2 days of abstinence. We don't want it any more than 5 days because we don't want the channels to get clogged up in any ways.
Mhm.
So when a sperm analysis is done, The ideal thing to do is to do it in-house in that facility, but it can be done at home as long as it's brought to the clinic within 45 minutes of the time that it's ejaculated. And we also want it to be kept warm at body temperature.
Mhm.
If you think about it, outside is 20 degrees colder, and that's a little bit of a shock to the sperm itself. It likes that nice warm body temperature. The other thing that we ask most males to do is to drink enough water the day before so there's volume to the semen.
Mhm.
When they collect, they bring it in and it goes into the laboratory. And the lab is going to look at about 20 different parameters. There are things such as color, viscosity, those things that really don't make a huge difference unless there are particular issues like if we see red in the semen, we're worried about an infection or some bleeding that's going on.
Mhm.
But other than that, there's not too much to do with color and things like that. What we are interested in is a number of different parameters that help us determine what's going on. For example, it sounds crazy, but we look at the volume, and the volume should be between zero point 0.5 and 5.5 mLs.
Mhm.
If we were to turn around and get more than that, and the pH is above 7.8 of the actual sperm, we think that there could be a condition in the pituitary gland where there may be a cyst or a tumor, and the doctor may order an MRI to make sure that the hormone production is on scale and that there's no further down the road issues with that particular patient. But when we look at the actual parameters, there's about 20 to 25 different parameters that will be collected at the time that we'll look at. There are 3 or 4 that I really want to talk about that are really important. The World Health Organization has stipulated that all sperm should be measured in mLs, which means that if I'm doing it here or in Spain, the report should be the same that I could actually compare apples to apples. So the first thing we look at is concentration. How many million sperm are there in 1 ml of ejaculate? And what they're talking about is a healthy, normal male should carry at least 15 million sperm for every ml. If
Mhm.
there's 14,999,999, it doesn't mean they're sterile, but it means that there is an infertility issue or potential issue that's going on. Most males in the United States are walking around with about 40 to 45 million sperm for every ml, about 3 times what we're looking for on average as a normal or as characterized as a good sample. The second thing we're looking at is the motility.
Mhm.
We want to know how many are swimming, and we're looking for 40% of the sperm in any ejaculate to actually be swimming. Now, when we're talking about swimming, we can grade their forward progression in a scale of 0 to 4, where 0 means no movement, 1 means the tail is just twitching every once in a while, and 1 plus it's moving a little bit more. 2 is normal, 3 is getting a little fast, and 4, you need a net to collect them because they're moving out the door pretty quickly. So we can measure their actual forward progression, but we're looking to see that 40% of them are moving the right way. The third and final major category that we're looking for is called morphology or shape. So there was a Dr. Kruger, and what he did was he took pictures of a very perfectly looking sperm. And now we look under a microscope, and the microscope's got what's called a macular device. And this optical setting divides the actual specimen up, looking as if it was looking at it through graph paper. And each one of those little squares of the graph paper is called a high-powered field. Each of those high-power fields, they look at 300 different sperm that are on there, and they're looking to compare it against a perfect sperm. And if they find 12 of them, which is 4%, it's considered normal. Anything above that is normal. Anything below that, they say they can have a small issue with causing fertility. So how does the doc use that information when he sees the patient? Well, very simply, if you take the concentration and multiply it by the motility, you get what's called the total motile sperm count.
Mhm.
So let's pretend the person has 60 million, 60 million sperm as the concentration, and their percentage of movement is 50%. If you multiply 50% times 60 million, you get 30 million motile sperm. Any number above 20 means that the male should have no problems having natural intercourse. If the total motile sperm count is between 5 million and 19.9 million%, then we look towards IUI, which is called intrauterine insemination, what we would commonly call artificial insemination. That's what would be required to go on to have a baby. And if it's less than that, 0.1, which is 100,000, all the way up to 4.9 million, then the sample is excellent for IVF care, where they literally take one egg, one embryo, and match the two of them together. So that's how we use it, and that's generally done in the first round. Now, we can go well beyond that with sperm analysis if we effectively have issues, such as if we have a sperm analysis and it's normal, but the gentleman is a little bit older and they're still having problems with having babies. Dr. Bastuba may look for DNA fragmentation indexes where the tips of the actual X or Y chromosomes are chipping off, causing problems. We can look for capacitation scores. That's the ability for the sperm to actually break into the shell, crack the shell of the egg, and we can look at that and get a score for it to tell us whether it's normal or abnormal. So they can do additional tests if necessary, but usually for about 90-95% of males, the comprehensive or complete semen analysis is what we need to do to start with.
Okay, thank you so much. And guys, I know it might seem like a lot of information, but if you were to look at the, typical template of the semen analysis and look at those numbers, I think it will really make sense. So let's talk now about cryopreservation, how, so you're doing collection, right? And then it might, so there is analysis, then it might go immediately into the procedure, right? Without going through any steps of freezing. I know, like, for example, we had some cases where based on this analysis, it was not possible. So it was only was being used for IVF. So IUI was not an option for the family. But more than that, the fertility doctor determined that it needs to be only fresh collection of semen. So it never could have been preserved. So what is the difference then? So what are we losing parameters of how we or how your lab and doctors are making those decisions?
Well, the reason that a laboratory would want fresh only is when they get very, very low volumes of sperm, and that sperm could have damaged tips like the DFNI, the DNA fragmentation index problems that are hard. So what we do is we would collect them. Dr. Bastuba would collect the tissues at source, which is from the testicle themselves, just after they've been produced, and they would use those for IVF. Now, we work with 13 different IVF centers here in Southern California, and collectively they probably do about 15 to 18,000 IVF cycles fresh every year, and probably only 120 of them are these low volume needs. So it's really not the majority. The majority are what you talked about earlier on. So how do we decide? A patient will talk to us, and the first thing that they're going to do is tell us what they want. And they're going to say, I want 1 child, 2 children, 3 children, 4. I want a family of 12. Whatever it is, we're going to listen and find out. We also need a little bit of history. For example, if that patient is an oncology patient, a cancer patient, you're going to expect different things to take place in lower volumes, so we're going to want to collect more often. Not necessarily, but there's a good chance of it that we'll know from the first analysis when we get our first sample. We also care for transgender patients and hormone-treated patients. So Each patient takes a little bit of a different variation on them. And once we find out what they want to do, then they're going to tell us, I want to do this with natural intercourse. I'd like to do it with IVF. I'd like to do it with IUIs. And that begins the process. So it's a conversation with the actual lab technician that sets up what their desires are. And they actually fill out a form and check it off, giving us this information. In the lab, we do a semen analysis. And once we have a semen analysis, we have all of the data. So let's say that this patient says, I don't have the best, I'm in the Navy. I'm not going to be home, but I want my wife to have a chance of having a baby while I'm being deployed. So she's going to absolutely have to use what's called IUI technology. So what are we going to do? We're going to make up 4, 5, 6 vials. So let's pretend that the total motile sperm count comes back at 80 million. With 80 million, I'm looking to have anywhere from 5 to 20 million per vial based on their total motile count. And if that's the case, I can take his 80 million and make up to 4 vials of IUI from the one ejaculate.
Mhm.
That means we now have stored for that family 4 vials, and he may give us 2 or 3 samples, giving us 10 or 12 vials that we can work with. And then while he's gone, his wife can go through an artificial insemination cycle to hopefully produce a child.
Absolutely makes sense. So yes, so once again, like your situation really matters, right? The situation of each family, each patient, the priorities. So just because someone think that something average, or sometimes families are coming and saying, my friends have done, or I read, and majority, right, are doing this. Or the question is, which always kills me, hey, everything's great, but what does most of your families do? And the answer right away, it doesn't matter what most of the families do. It's really important to understand, but what do you want to do, right? What is your situation? And
Absolutely.
yes,
We're all unique individuals, and based on what your physical characteristics are like, what the medical characteristics are, and what your goals are, we try to absolutely individualize things and plans for individual people. And that works best.
yes, absolutely. Well, I had a big honor to actually go through the training with you and with Dr. Bastuba and with your lab supervisor and team members. It has been absolutely phenomenal to see and be part of the procedures and actually, witness some of those questions and, the steps that you're going for. So, for example, you were talking about, this graph paper and, where they could identify 300 per each square. Yes. I was looking through the same microscope, and guys, my immediate question was how they even do it. Like I don't understand how they can. And my question was, well, would because you hear, for example, AI or some technology could do things, and immediately Mel said you said that no, there is no technology that could be better than what a trained technician, what a trained eye can do. How would you talk about that? Because I thought it was fascinating.
I feel very strongly about that. I think that in these high level, this lab is called a high complexity lab for a reason, because there's a lot of things going on, as you saw. The training of the individuals, first of all, they have to have backgrounds in microbiology or the neurosciences, something that allows them to have lab experience going through university. So they're all degreed personnel. Secondly, they are trained, retrained, and tested and retested on a monthly and quarterly basis and need to make specs. So it's kind of interesting that we'll collect a sample with known information. We'll give it to each one of our technicians, have them tested, and they have to be within 15% of each other or there's an issue with their training. And they're really, 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 I'm very proud of these people because they do such a phenomenal job, and they'll do it at the drop of a hat. So they can be fully busy, and a patient who comes in, drops in because they're getting chemotherapy the next day, they need to have an analysis done and freezing done that day, and they'll fit them into the schedule and work it up as if nothing else happened.
Well, guys, this is not just the words. I'm telling you, I witnessed that. And in already several years that we've been working together, I could echo every single word that Mel has said. Incredible team, incredible gift, just in a sense of care and prioritization. I don't know. This speaks volume to really how they organize the whole company and how they trying to service you in the best way possible. Um, I know also like there was something that really stood out at me. So you said we are really the only facility that could do cryopreservation, and maybe I'm misstating. Please correct me if some words not exactly, but you said we could do forward progression that you were talking about, not just for the semen analysis, but actually for the samples when they cryopreserve. No one else does that.
Well, not quite true. Anybody who delivers it to the lab, everybody can do it that way. And everybody can do it if they bring it from their home within 45 minutes. We have an alternative called a Cubby Kit, which is an at-home kit, which can travel all across the country. So we could have somebody in Boston sending it to us here in San Diego. It'll come in overnight. We're the only group out there compared to all the others that are currently doing it that can actually give forward progression, which is really necessary to determine whether or not it's going to freeze properly and whether or not it's going to thaw properly and be useful. So that's the one area that's a little bit of a distinction for those long distance people.
This is huge. Yes. So imagine, so if, yeah, like, you could be not in San Diego, you could be all over United States, right? I don't know, maybe even outside of United States. I'm not sure.
Right now, we're doing it, for example, in Louisiana, there's an oncology department who every male who goes through that sends us the samples from their location before they get treated. So we know it works with long distance in good weather and in bad.
It's phenomenal because then it means that yes, you could do it from your place. You don't have to travel to San Diego, and then you already could have so many processes started. So we use it with some of our families as well, especially if we were doing international actually surrogacy program. That's a big one, for my team. So the men would do it's a surrogacy program with egg donation typically. Yes. So let's say egg donor and the surrogate is outside of the United States, but the man is in the United States. So imagine how much money could it save that this process could be done where the semen could be properly evaluated ahead of time before even collection is done. Yes.
Yeah, and you know exactly what you're getting into before you get into it.
Exactly, exactly. Because worst case scenario is where assumptions are being done, right? And usually in male, and this is maybe another, subject, but maybe we could touch on a little bit about it. The reason I'm personally so excited about spending as much time with Mel, Dr. Bastuba, discussing the male fertility, because a lot of times we, female, we think that we're going to go through any type of evaluation and study analysis and everything, and men just it's going to take 1 second and that's it, everything is done. It's kind of by default assume that it's just me, right? It's just my female side, and here's my issue, there is something wrong with me, and it's not the question what's wrong or not, but when we do a cohesive analysis of both sides, that's really when the magic is happening. Mel, could you speak about that a little bit?
Well, you're absolutely correct. And you have to think about it a little bit differently, but women go to doctors all the time. Men have to be brought dragging to the doctors on a normal basis because we always think we're healthy and we're going to be okay. When you look at infertility in the United States, about 40% of the time there's a female factor. 40% of the time it's a male factor. 15% of the time it's a common factor, some male, some female. And 5% of the time it's unknown. We don't know what it is. But you look at the male side, it's the easiest and fastest way and the least expensive to work out and diagnose. A simple sperm analysis at the beginning tells us just about everything we need to know at the beginning about what's happening with that male. So it's great if they do it. So at our program, we have over 300 gynecologists that actually send us patients to have semen analysis done because the woman has gone to their OBGYN to say, I want to have a baby. They're taking the first step. And the gynecologist says, well, Let's get the male taken care of right away. Here's a prescription. Go get a semen analysis done with your husband, and it's done and over with. And that allows them to get it started. So you're absolutely right. We ignore the male for the most part, and that's partly our fault too. We don't want to come in if we don't have to. Another beauty of our Cubby Kit is the fact that
You
the
don't have to
guy
come
in an
in.
IVF center doesn't even have to go into the IVF center. He can give the sample. The samples get brought back to us. They get made into IVF ready tubes. Those tubes are then transferred frozen back to the IVF center, and they can use them anytime.
Yes, 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 guys. You know, I have seen also the outcome of that. So, for example, and I guess, you know, I understand. So we always want to do everything fast, right? You know, typically when we come to the idea that we want to have children and suddenly child is not happening, you know, in a natural way, then we're working around, you know, against the clock, right? We're saying time is not on our side, rush, rush, rush. I want everything to be done yesterday. And so, you know, Mel at the start, he was talking about the time, you know, 70 to 90 days, correct? So, you know, 90 days, this is 3 months. So if we, you know, by the time there is any, you know, semen analysis is done, right? And maybe there is some challenges I identify, it's something that you don't fix overnight, right?
Right. Exactly.
Yes, and so perhaps the notion is, well, you know, who cares? Let's just get it done. Somehow magic will happen. Sperm will be collected. The doctors will create the embryos. It doesn't matter. They can do it. Okay. But it's not quite right, Mel. Add
Yeah,
to
it
that.
could be something as simple as we can take some nutritional supplements to fix the sperm. That's all it's going to take. But if you start them today, it's going to be 90 days from today before you start seeing positive results. And it'll be even stronger after 120 days. So it does take time. We always say there's a biological clock that's ticking in. For women, it is. And it's real in certain cases that we have to be very careful about. And unfortunately, it's based on age. And age at 35, 36 doesn't sound like it's very old because it's not, but reproductive wise, it's getting towards the upper ends of things. So we try to push the challenges a little bit faster and a little bit harder at that particular time. But for males, again, it's very, very simple to have all this done.
Yes, absolutely, absolutely. Well, otherwise, the downside of it, guys, you know, I've seen some families that would come after the fact. And remember, I'm more dealing with surrogacy. Surrogacy, in many cases, is your last case scenario. It's not your first choice. You know, there are situations, yes, you know, there are same-sex couples, or, you know, there could be, you know, single family households, you know, simple parent, I should say. Yes, I never could say patient or customer. I always call your families to me. But I have seen where the journeys have been so long, and you know, women would go through many, many rounds of egg retrieval, and then there is reoccurring losses of pregnancy or no pregnancy. Then they come and they get to the idea of egg donor, and suddenly there are several rounds of egg donor, right? So when we're talking about the time when things are not being done properly, and we think that we're saving time, at the end, what could be at the ground zero. And then the question is, well, hang on a second, but why all of that is repeating? And Mel, we were talking with you, right? When some of those patients come to you, some of the families, and you do get to the male side, it's exactly falling into category where you were saying it's 40% female, 40% is male. So if it was identified earlier, what a difference would it have made to the family's journey?
Absolutely, it'll shorten the time overall. It makes a huge, huge difference. We have a lot of women who will come in and want to have a baby, and they're bringing their husbands along sort of into this program. For them, there's a time commitment. I'm good, I'm healthy, everything is okay, I don't need any testing. But to me, that's doing it blind. For women, we need to identify 3 steps. For males, one, we just need to know if they've got good sperm. For females, we need to know if they've got eggs, if the egg and the sperm can actually meet, and whether or not there's a safe place to grow the baby in the uterus.
Yeah.
And those testings can take 10 days from beginning to end. So it's not a lot, and it's not very expensive to actually have those done. But once you have those questions answered on both the male and the female, you can look at all of the options. And instead of just having one option, you may have 10 or 12 options.
Exactly.
If you're given all the information with all the chances and the right numbers and stuff like that, that family will make the best choice for them.
Well, I think this is a golden words. And guys, if you don't remember anything from this meeting, remember what Mel just said, okay? Because that's all about your success. And it's definitely possible. And now also, hopefully you have understanding a little bit more about the numbers and what they're looking at. Doctors are looking in the sperm analysis. And also it does show to you that, yes, we're not all superhumans, right? You know, there is variations. And the faster we know all of these parameters, the better solutions could be offered. So let's get the things done right. And if you're looking to fertility specialist, and if any questions, definitely Dr. Bastuba team could be one of them.
Thank you, Maria. Enjoy talking with you.
Thank you so much.